Okay, so yeah, thanks for joining. I am Jamie, and this is part two of this series, Psychodynamics for All. And we're going to talk today about passivity, about the issue of client passivity and what that might mean. Um, so just before we get started, a little bit about me. I'm a counselor. I'm licensed in North Carolina, South Carolina, and Florida, and I practice experiential dynamic therapy. Specifically, I'm trained in ISTDP, which stands for Intensive Short-Term Dynamic Psychotherapy. So this is a present moment focused model, highly experiential, a big emphasis on overcoming repression and opening up to repressed feelings and other content. With a really deep roots in the psychodynamic tradition. I'm also a Zen Buddhist priest and a mom, and I write a blog and a little podcast. So, just a little bit about who I am and what I do. And this presentation, like these ideas, right, I'm pulling them from psychodynamic theory and also from relational theories. A lot of it comes from my own training and supervision in the ISTDP tradition. And then, of course, this is filtered through like my experiences, through my way of seeing. So it's not a theoretical download. It is very much like my take, to be clear about that. Yeah. So as we're going through this, this is a little agenda for what we're going to do. So I'm going to go do a little lecture, just call it what it is, tell you guys my thoughts about defining and identifying and responding to these issues of passivity. We'll have some clinical examples. And I'd like to build in like discussion time, Q&A time throughout. And if something comes up for you, feel free to. I think the easiest thing for me to see it is going to be if you put something in the chat or use the raise hand feature. Um, yeah. And I guess just to also say that we will end on time. So if any concerns about that. Okay, so defining passivity. The way I am defining passivity here is as an unconscious agreement between the person and their therapist that the therapist is going to be the main location of will, curiosity, energy, an understanding of their problem, of knowing what to do, and of setting the standard for health and wellness. And so the patient's job in this formulation would be to show up and answer some questions and then submit to treatment, right? To be um, for the therapist to be the one that's doing in this case. Okay, so it's easy for this to become dominant for a lot of reasons. One being that, like, we were all trained in graduate school, at least I was in the medical model, right? Where that's how it works. Like, you go to the doctor assesses you, right? And then, like, provides treatment. Um, and so we're taught to do an assessment, formulate the problem, create a treatment plan, and then do the interventions, which is not bad. Like, in some like formulations, that's true. That is what we do. Um, but we want to make sure that that the person in therapy is truly active and that the will and the curiosity and energy and understanding and knowing is really primarily located in them, that it's coming from them, that they're there and they're invested, and that you're there and you're invested in helping them. Um, but it really extends beyond that relationship, that you want them to take those things into their life. Yeah, so we want a relationship that's going to be as equal as possible, um, and where the person feels really strongly that you're working together to overcome problems that really matter to them. Yeah, so when passivity is dominant in the relationship, when it's out of balance, it can feel really transactional. It can feel like a person is giving you something and then they expect you to sort of fix it and give it back. It can also feel uncomfortable, scary, kind of icky. I've had experiences where, especially people who are really traumatized, where they are scared of what you're going to do to them if there's an assumption that you're going to do something to them, or that they're going to have to kind of grit their teeth through something painful that you're going to do. Um, yeah, and so if this is like dominant, if this is operating in a dominant way, people have a lot of different feelings about it, even if they're buying into it. They're like, okay, yeah, I'm the one that things are done to, and you're the doer. They might think that's great. They might feel pretty comfortable in that position, or they might be really consciously or unconsciously pissed off at you for controlling them. Or they might feel afraid of you, like I said. And yeah, this is a ubiquitous and rampant sort of like issue in therapy from my point of view. And I'll say a little bit more about why I think that is in a minute, but just to say that it's a therapy issue, but it's also, from my perspective, a political issue in terms of it's like a feminist issue, right? That we don't want power over people, we want power with. And so when we work to neutralize passivity, it is an act of anti-oppression, and it's an act of working against institutionalized power hierarchies. Um, and that it's really a move toward this like personal and collective liberation from those cultural imperatives. So that might be like pretty heady, but I really do see it that way as that's part of what we're doing when we try to neutralize the um, like energy imbalance that can happen in therapy. So for some people, that's really like the main source of this. It's going to be just like this is just how I've learned to that like getting help works, especially if it's like a sense that it's like a medical experience. But we can also kind of deeper than that, people can have really personal reasons for taking a passive stance. Uh, so in psychodynamic therapy, we call this a defense, right? That when some part of us is too painful or incongruent or shameful to allow into awareness, we repress it, we push it out of awareness, and in order to keep that happening, we employ defenses. And so passivity, taking a passive role, can be a way of avoiding conflict, a way of avoiding aggression in their own self. It can be a way of avoiding anger, and even a way of avoiding having your own will, right? That if that's something that you've learned is like not acceptable, or you're going to be punished for, or ends up in shame or fear, then it's really important for you to deny that you even have a will, that you want things, that you have energy toward things. And so passivity can be used to counteract that and to give yourself a sense of safety. And so, we can locate that sense of power and activity in someone else. And in this case, in the therapist, right? I don't want to get well. I don't want to work on these things. You want that from me, is one way that it can work. And so I have this categorization of tactical and characterological defenses. Psychoanalysis has like the most, I don't love the language that they offer, but the concepts can be really wonderful. So a tactical defense is like it's pretty surface level. And once we address it, it just kind of falls away. And so if we were to just stop taking the lead, people who are using passivity as a tactical defense will probably just fill the void and begin to be more active. And a characterological defense refers more to um, kind of like deep, almost personality level. Like we all know these parts of ourselves, or hopefully we're working on knowing these parts of ourselves, those automatic patterns that we bring to almost every relationship that we're in, right? And so if somebody has sort of a pervasive habit of passivity in their life, that's going to show up in therapy, and it might even end up being a focus of therapy. It's not something that's going to get kind of dealt with and moved on with easily. Yeah. And so I'm going to keep talking for another minute and then I'll break and see if anyone has any thoughts or questions. Um, okay. So I want to talk about institutionalized passivity, and as this is like a pretend array of TikTok therapists slash self-appointed mental health experts with all of their ideas and advice, um, packaged in 20-second increments. And this came up for me. I read this wonderful article some time back, um, that was written in the 90s it's in the references. I'm happy to share it by this Von Korff is the person's last name. And so he's writing way before TikTok. He's writing in the I think 1998. And I edited this quote a little bit and took some things out so that it would be a little easier. But he says, some patients present with a lengthy history of prior therapies and a relationship pattern in treatment which may be referred to as an institutionalized transference. This term originates with the fact that many such patients have been treated for years in clinic settings by a series of interns or other transient staff. In the process, these patients are confirmed in a type of treatment alliance, which is both highly dependent and highly detached. Their expectations of themselves and of the therapy itself are often strikingly limited. In the event that they do find their way into a more stable treatment setting, they enter without a clear sense of goals and without a sense of urgency. They anticipate that at best, psychotherapy will have only a marginal impact on their lives. And so they're talking about, in the past, just like I'm sure anyone who came up in community mental health is aware of this phenomenon that someone will have like 8 therapists for like 3 months at a time because they don't have insurance and it's free and they're kind of like, but there's a sense in which that I think this is definitely my hypothesis, like that process is happening to a lot of people because they are interacting with therapy adjacent content every day with no relationship attached to it. And so it's really easy if you've consumed hundreds or thousands of hours of this kind of content, um, that you can end up in a real therapy relationship expecting that it's going to be mostly explanations, or something that you're going to learn, kind of passively take in, and that it can be challenging to realize that it's actually like you're going to enter into a vulnerable and complex relationship with another person where you're going to be an active participant in getting to know your inner world, right? Like that's a big leap. And so it's partially our job to like educate implicitly and explicitly our clients, the people that we work with, and invite them into this more active stance in therapy. I don't know how long I'm going to be able to let this play in the background, but I wanted to let it play for a second to talk about transference and enactments, which are very much like a dance where all the steps are already predetermined. So this is a psychoanalytic, psychodynamic concept, a transference enactment. It's when someone, in the case of passivity, it's someone's being passive as a part of a larger relational pattern in their lives. Um, and so, yeah, just to define it, it's like a relational template from the client's life becomes dominant in the therapy relationship. So in the ISTDP world, we use the word the shoes, right? That the person is asking you to step into the shoes of their mom, of their stepdad, of whatever attachment figure, kind of helped solidify their relational patterns, that you're being asked to play out that same relationship. So I got a little Virginia reel here to show kind of what that feels like, but makes me a little dizzy, so I'm gonna stop it. I'm gonna say a little bit about this, but I want to also make the blanket statement that which I kind of alluded to, that I find these concepts really helpful, but I want to use them in a way that is non-pathologizing because the history of these concepts is highly pathologizing. Um, And so just to say that I'm not talking about something weird and bad that like those people over there do that they need to stop doing. I'm talking about like a natural way that we as human beings like relate to each other, right? By saying, okay, this is how I exist in relationships, and I'm going to show up, and that in some ways allows a consistency of how other people relate to me. But when that becomes really rigid or dominant or inflexible, then it causes a lot of problems for us. Or if that position is doing harm to us in our lives. And if you come to the part 3 in August, we're going to talk about this a little bit more and about how it relates to projective identification. But for today, we're going to keep it a little more simple. Um, Yeah, so the client is doing their relational dance. They're inviting us to do our half so that we can dance together. So an example would be if someone grows up in a really, this is obviously really simplified, but if someone grows up in a highly critical, high control household, right? And then they come to therapy sessions late and like reeking of marijuana and like are obviously high, right, in session. And the therapist, if they sort of just like, or maybe get caught up in this, right? And they start doing their side of the dance, they're gonna become kind of punishing and controlling in response to that, right? Like, you cannot do this. Like, I have these boundaries, and like this isn't. And so now you're both acting out this relational pattern from their past, which they have invited you into, and you've taken up the other side of. So, see if there's anything else. Yeah, I guess just that the biggest signal that it's happening is that we feel under pressure to be a certain way or to act a certain way. And so this is all happening unconsciously a lot of the time, and we might not even have a sense of what's going on, except that we feel anxious in session and we feel almost like it feels pressurized. We feel this like, oh, I know what this person wants me to do, and I feel like there's going to be some kind of negative consequence if I don't um, like get on board with that. And so in the case of an imbalance of responsibility or an imbalance of energy in the therapy relationship, the client they might be unfocused or kind of low energy or lack a sense of will. I don't know. Like, what do you think I should do? Which could be a reenactment, right, of a childhood that was defined by their autonomy and individuality being suppressed, among a million other things. That's just a like one possible hypothesis. Okay, so how do we know, or what are the signals? What are the signals in client behavior of passivity? So I had a supervisor who talked about this a lot, who would talk about the expectant look, that someone will say something and then give you a look that is like, okay, your turn, right? Like now give to me like what needs to be given to me. This is not a real person. This is an AI generated image because it's very hard to Google person looking expectant. They're just a bunch of pregnant people. Um, And then, yeah, there can be like literal body language, like this little girl over here, right? Like sitting back in the chair. I've had guys kind of even put their hands behind their heads like that. There's really this kind of like, I'm here to receive. Um, you might notice people are eating, checking their phone. Maybe they're coming to session after just waking up. Or just sort of generally there's an air of like, this doesn't require a lot out of me. I'm just kind of like showing up. It doesn't, I'm not here to really work. I'm just here I'm doing my part just by being here. And obviously there are a lot of other sources of these behaviors, like doesn't mean anything definitely, but maybe just like can start to wonder if it's part of a pattern. You might notice people seeking your advice a lot. Um, You might notice that the conversation revolves around what you as the therapist wants and thinks and is curious about. So you'll hear like, you might ask a question, and they'll answer it and they'll be like, well, is that what you wanted to know? Um, or right, they might even start doing reflective listening to you, right? Like you'll say something, be like, okay, well, here's what I think I heard you said. Did I get that right? Which would, like maybe that's okay, but if it's part of a pattern, then it's like, wait, is it more important that they understand my experience or that I understand that we together understand their experience? If there's like a lull in conversation, you might start to feel pressure that it's your job to pick up the thread to know what to say next. Um, you might feel pressured or decide to start the session to say, okay, here's what we're going to talk about today. Let's pick up where we left off last week. Um, and it might feel like you're primarily the one that is making meaning of what's happening, right? Which is obviously that's going to be the meaning you're making. But what we want for the people we work with is for them to make meaning for themselves about their lives. And you might hear people complain about or talk about other people controlling them in their lives, right? They might say things like, I feel like I never get to make my own decisions, or I feel like I'm just watching my life go by, or I'm a side character, I'm in the passenger seat, things like that. And if you yourself, if they're saying this to you, and then you also yourself feel pressured to control and make decisions for them, then like that's a good signal that maybe this is something that's a bigger issue for them that it would be, if you guys can get on the same page about that, you might be able to really help them with. Um, Yeah, and just like a minor theoretical side note, is that I don't want to communicate that I think that people can actually achieve full control over their lives, um, but that having an internal locus of control tends to lead to better outcomes. So even if it's not true, just having a sense that like I do things and the things that I do have impacts on my life, that's it's a healthy state of mind. It tends to lead to better outcomes for people. And then recognizing passivity from the therapist's point of view. And I put this picture of the thousand-armed Kanon. She's or I guess this is the Indian version, which is Avalokiteshvara, a thousand arms, each with another implement of helping to relieve suffering, which is a beautiful image. But if we feel like we could somehow be that way, right? That we could really whatever's needed, we can provide it to relieve people's suffering. That's a pretty for me, that's a pretty stressful position to be in. Uh, so, I love what Rachel was saying that this person said, I have a lot to learn from you. And there might be cases where sometimes that feels like it wouldn't even rise into awareness, but she noticed like, it made me uncomfortable, like something about that in this relationship puts me under pressure that I'm not comfortable with. Um, So yeah, as the therapist, you might feel a lot of pressure to do something. You might feel really responsible for the outcome of therapy, right? Like we do, like it's so important that we communicate hope to the people that we work with. That's like in the research, like very high on the list of things that like leads to people staying in therapy, people getting something out of therapy, that they have a sense of hope. But we can't hope on their behalf, right? We have to communicate that we believe that they can do the work necessary to change or to make change in their lives. But I can't create that outcome for them. If you are working with someone who is highly passive, you might feel really exhausted after sessions. You might feel even resentful or frustrated with them because you're trying to do something that's impossible, right? To be responsible for their inner experience or their life. You might find yourself taking responsibility for things between sessions, right? Like if you guys are talking and there's something to like Google or follow up on that you're like, oh, I'll email it to you, right? Which is like totally fine if they were interested in it. They could have written it down and done the exact thing that you're going to do on their behalf. You might feel that pressure to like, yeah, to add kind of extra things to your workload. Um, yeah, and just in general, if you are inexplicably anxious or confused or irritated, there's a good chance that there's some kind of something happening under the surface, right? That for me, I'm like, okay, that makes me ask the question. I'm like, I don't know why I feel so confused right now. I feel like I just don't know what's going on, or I feel like just like really uncomfortable. That it's not necessarily passivity, but it's a good signal that there's a defense, a defensive system that's activated. And then just to think about how you might be feeling um, through the power of projection, what they themselves can't tolerate feeling. So you might be feeling helpless or hopeless or incompetent or something like that, which are experiences that they're very uncomfortable within their own being, and so they're being projected. So those are some things that you might notice as a therapist that would add to your curiosity about what might be going on. And we're going to talk in just a second about interventions. But first, just a couple of caveats. We don't want to over pathologize. We don't want to blame the people that we work with for like, I don't know. I feel I've heard been in contact with teachings that include some of these ideas where there can be this vibe of like, I don't know, like, yeah, passive patients, right? And this is what they're like, and this is who they are, and this is why they do. And that makes me really uncomfortable. So I just want to be clear that like this isn't the point here is not to like know something for sure, but just like to help us like be more curious, to be more open to what might be going on. Um, yeah, and that it might not be passivity. Compliance is a little bit different than passivity. Compliance is like, I'll just do what you tell me to do. But you can be passive and still, it's a little bit like, yeah, tell me what to do and then F you for telling me what to do, right? That's totally also possible. You don't have to be compliant in order to be passive. The person might actually need psychoeducation and instruction, right? They might actually not know something. Um, or they might be just confused about what therapy's like and need some support on that. Like that it might not be an issue of compliance. And then, yeah, iatrogenicity it's like if you go to the hospital and you get an infection while you're in the hospital, right? That the act of care is making you sick, that it is possible that the therapy relationship can cause someone to start being passive. That if we have these beliefs in ourselves that we're attached to, that we are a therapist. We are a person who heals. We fix people. We solve problems, right? That we can actually create this in the relationship where it might not have been there otherwise. And then the last like risk I wanted to be aware of is that if someone is using passivity as a defense and we take that away or we identify it and it starts to crumble, we don't know what that's defending against, and it could get very intense. And so we just want to be aware to, yeah, that we don't know what's going to happen next if we push on this stuff. Okay. So I wanted before I talk about, oh, got something in the chat. Yeah, right. Mary says, I often help clients recognize a type of rescue fantasy which is underlying. Totally. So I wanted to make the distinction before I get directly into specific interventions around content and process, where um, content is the client's job, process is mostly our job in collaboration with the client. Just so that when we're talking about interventions, there's like this context of some of these things. So I just made up this little vignette. Like, what would you like my help with, right? So we're saying, what is the content that you want to talk about? And the therapist might say, I don't know. What do you want to know about me? What seems important to you? And, I might say, I don't know, right? They're inviting the therapist to be in charge of content. Because I don't know, that feels like something you'd know a lot better than I would know, like what's important. They say, well, maybe we can talk about my relationship. Does that seem okay? So now they're bringing up some content, but they want to make sure, they're tentative about it. And you're right, the content's up to you. It's really up to you. Whatever, I trust your sense of what's important. And then, right, there's this content. We've had a lot of arguments in my relationship. It's been stressing me out. That's the content. My job as the therapist is to bring the process. That sounds really tough. Let's look at a specific example of that happening. So, whatever your therapeutic framework is, um, but just to be clear, I'm not saying that we are expecting clients to do therapy by themselves, but just to do their part of therapy. And that we do have things to offer as therapists, of course. So in terms of specific interventions, um, in general, what these interventions are trying to do is to make the implicit explicit. So if you just kind of go into therapy relationships unwilling to be in charge of the things that you don't need to be in charge of, there's like two major things that are can possibly happen. So one is that they pick that up really intuitively. They understand, oh, okay, this is a place where I need to be in the driver's seat. And you go from there. The other is that the person gets really uncomfortable because this kind of goes against the dance that they're used to dancing, and a lot of things that can happen from there. And so that's where I'm saying the best bet in a lot of cases is if we can make that conscious, um, if we can bring awareness that it's even happening. So if we're pretty clear, that first bullet, that it's not, that we're not creating this, right? That we are looking into ourselves and saying, am I being overactive or hyper responsible here? Um, and we determine that there's something to work with here intervention wise. Our first line of defense can be to just do less, to just be like I have a 7-year-old son, and he would love it if I would put his socks on for him every single morning. And we have this little he hates it so much, but his dad and I, we both say, helping is not helping, or doing for you is not helping. And of course, sometimes we do it because he's sick or he's tired or we just love him and he's our baby and we put his socks on for him. But in general, we want him to have the experiences of, he needs to practice putting his socks on to become a functional person in the world. And so we have this like, doing this for you is not helping or helping is not helping. Um, yeah, so just doing less. Like an example that comes to mind for me is like, and this might be controversial, people might disagree, but at the beginning of a first session, I just say, do you have any questions about the paperwork? And people say no, and then I move on. And I'm going to assume that they have read the things that they've signed and that they're agreeing to them. And if they had questions about it, there's a chance to ask, but I'm not going to go over it again. To just sort of from the beginning, there's this like, I trust you to be like to be in charge of your half of this. Um, yeah, so I just try to undermine passivity as much as possible, as early as possible without risking the relationship. So another kind of category would be like just being free. There's this wonderful paper by this guy Symington called The Analyst's Act of Freedom as the Agent of Therapeutic Change. Is that when we can really be ourselves in the therapy relationship, that it's can be a huge intervention toward, yeah, that it's good, it's helpful. So we can notice. What I mean by that specifically is if you think about that like Virginia reel, right? You notice like, oh, I'm being asked to engage in a dance here, um, to recognize that pressure. And then it's really hard, right? To be like, I am going to reach towards something authentic to myself. Like I'm going to not continue the dance. And so that's like this little picture here. This person is holding this hot potato and it's so painful. And the woman's like, oh my gosh, that's so painful. And then he's like, you hold it, right? And if she had caught it, then like maybe they wouldn't have to become aware of it. But she doesn't catch it. It lands on the ground. And then they're side by side instead of across from each other. They're looking together. What is this? How did it get here? What just happened? Right? Like, what is this potato and why did you throw it at me? And like, what does it mean to you? Right now, we're not just enacting, we're not just doing the dance, but we are aware that the dance was happening, and we're um, so that like acts of freedom um, creates this like implicit pressure toward being in charge. Right? The hope is that rather than just playing it out, that they actually say the thing. I want you to be in charge. I want you to tell me what to do. And then you're rolling. Then you can talk about it. You can use silence in that way. Just leaving an extra 2 breaths, right? When there's a lull, and see if they will kind of take up the decision about where to go from there. We can engage their will and their sense of choice. So when they say, what should I do about that? You can say, I'm not sure. Like, what do you think? Or you can start sessions just by, where should we start? Right? What feels important to you today? Um, we can use immediacy, meaning we actually can say how we're feeling. It can feel risky, but even like, I'm feeling like I'm under a lot of pressure to be in charge right now. Do you feel that too? Like I'm supposed to be in charge of this? Um, Yeah, and then these last two, clarification and challenge, are specific to ISTDP. I can talk a little bit about it. I wouldn't suggest necessarily trying these things without some training and supervision because they're risky. But clarification would be helping the person become aware of this dynamic as it's happening, and then if it's possible and appropriate, making links to um, their presenting problems and like the risks or the what word am I looking for? Like the downsides, the what can happen if they continue this way. The costs is what I'm looking for. So it can sound like, okay, so when you take this passive or dependent position here with me in therapy, we start to form a relationship where we agree that I'm in charge. And like that sounds a lot like your relationship with your partner, how you barely get a say in how things go. If we do that here too, how's that going to impact your experience in therapy? So just being really clear about what's happening. And then challenge is when we actually directly encourage someone to stop doing something that they're doing. Probably one of the highest risk. You have to have a pretty strong alliance to try something like that. But it might sound like, you know, if you're talking about something that happened last week, as a therapist, so when your mother does that, what's that like for you? How do you feel? Patient or person says, I don't know. She thinks I feel angry, right? Okay, well, that's her idea. How do you feel for yourself, right? Like, what does that actually feel for you, right? They might say, well, how do you think I should feel? And you could directly challenge that and say, if you don't take a passive position right now, if you don't outsource your feelings to other people, how do you feel in this moment? To directly put a challenge against that. So I am going to, I think I saw something in the chat. Um, but also, yeah, let's, before we jump into some clinical examples, does anyone have any questions or thoughts right now? Thanks for watching. I ended the recording here to protect the privacy of participants and also the confidentiality of some clinical material that came after this. And you might notice that I edited portions of the video for the same reasons. I'm really glad that you joined. I hope it was helpful. If you have any questions, thoughts, comments, or you would like to connect with me in other ways, you can find me at my website, thegarland.net.